you?
Hello. Good afternoon, and I'd just like to welcome you to Cleveland Clinic, and thank you very much for joining us on this briefing about the coronavirus disease, COVID-19, a pandemic that is top of mind of every healthcare organization in the country. My name is Tomislav Mihaljevic. I'm the president of the CEO of Cleveland Clinic. I'm joined with my colleagues here, Dr. Stephen Gordon as a chair of Infectious Disease here at Cleveland Clinic, Dr. Robert Wyllie there at the end, the Chief of Medical Operations, and Dr. Brian Rubin, Chair of Pathology and Laboratory Medicine. We as a healthcare organization obviously have a big responsibility to take care of a large number of patients in every community where we reside. And we want to use this opportunity to communicate with you and through you to our community in the best way possible, in particular because there's so much information about COVID-19 and pandemic. There's also quite a bit of misinformation about it, in particular when it comes to the types of testing that is currently being done and is being or not being available. So we're here to provide you with the most updated information about the disease, but also on the actions that Cleveland Clinic is undertaking in order to serve our patients in the best way possible. So I will stop here and then I'll open it up for questions. Well, yeah, the first and probably the biggest misconception out there is the misconception about the severity of the disease. This is a serious disease, obviously, otherwise we wouldn't be standing here. The vast majority of patients, however, even if they contract virus, are going to have only mild symptoms. What we are really worried about is are those who have pre-existing conditions, chronic diseases such as diabetes, heart failure, lung disease, and who are elderly. Those are really at a higher risk of potentially contracting disease and having a bad outcome.
I have a question about, and a couple follow-ups to go with it, about inventory in hospitals. You know, at this point, how many mechanical ventilators does the clinic have available today, and how many respirator masks, swabs, beds, and then on a less specific note, you know, as things progress and we hit a moderate pandemic or perhaps a severe pandemic, are you prepared with the supplies?
So let me start from the end. Probably the most important notion that we have to have as a community is that our primary responsibility is to slow down and minimize the spread of the disease. And if we do that successfully, then obviously we're going to need fewer resources to combat disease because we're going to have fewer patients. So how do we combat disease effectively so that we do not get to the point where our supplies are going to be put in question? The responsibility lies in every member of our community. For us individually, every person that is currently listening or hearing what we're about to say, the precautions are well known by now, should be well known by now. Cough etiquette, meaning covering your mouth and nose when you sneeze. Careful hand washing. Social distancing, which by now should be a term that is well acceptable and explained, meaning staying away from the larger crowds. Avoid handshaking, avoid being in a larger groups of people. And lastly, staying at home if you're ill. Those are the most important components of precautions that each person can take. When it comes to us as healthcare providers, we have, so to say, a three-step process that we participate in and where we as a larger healthcare community are responsible for. The first is the access to the screening and the access to testing. Obviously, we're doing absolutely everything that we can to make the access to our care available to the highest possible extent. The second one is an ability to first screen, meaning determine whether the testing is appropriate, and then test. And lastly, the broader responsibility, civic responsibility, is for those who test positive and do not need to stay in a hospital to make sure that they stay at home. And they stay at home meaning that we support them during that stay at home, that the people's jobs and livelihoods do not get put in question by their ability to stay at home. What we have learned that if we do those measures right by the countries that have reacted in a way that I just described, the number of the patients that are going to be in a hospital is going to be lower, and therefore our need to be worried about the numbers of the ventilators and supplies for their care is not going to be as pronounced. We are currently well stocked. We have sufficient supplies. We have sufficient number of ventilators. We have a very large number of intensive care units. We're blessed in this country to have a really, really large hospital capacity, and we can flex it, meaning we can increase it on a short notice. That is a part of our emergency preparedness.
On that point you're making right now, can you be a little more specific? Because I keep hearing that we're ready. I haven't heard any specific numbers. How many intensive care beds do you have, and how many ventilators do you have? What is the capacity?
I'll ask Wyllie to provide you with the exact numbers.
Thank you.
So we have about 550 ventilators. We normally use between 100 and 130 per day, so that gives you an idea of the flexibility, and that's in Northeast Ohio. We are running about 3,000 adult medical surgical beds. If we stopped all elective surgery, and we have a lot of elective surgery within the Cleveland Clinic system, and we flexed up 150 additional beds by putting them up, and the beds are in town. We have them on hand. We can put them up and have them ready within about 4 hours. We would have an extra 1,000 beds within the system.
So I think it gives you a good understanding of additional capacity that is available. This is just within the Cleveland Clinic health system.
So that's like including all of your hospitals?
All of our hospitals in Northeast Ohio, yes.
Is that mechanical ventilators?
Yeah, mechanical ventilators, yes. Once again, the key is not needing a lot of mechanical ventilators, is to do a hard work on preventing people from getting ill.
Absolutely, but what are the models showing you? I know that the public health folks do modeling to try to figure out, well, what is the potential of the number of people who will show up, right? Is the modeling showing you that that's enough?
Well, the modeling depends on the effectiveness of public health measures.
Mm-hmm.
This is a new set of circumstances that obviously the entire world is facing, and what we can say that we are actually in a privileged position as a country, because we can learn from good and not efficient practices of other countries that have been exposed to coronavirus before us. So what we are seeing from the countries that have been very effective in containing the disease and reducing the number of the patients are the measures that I just shared with you. So modeling of the number of the patients and the capacity that it will need will be directly a reflection, not only of the nature of a disease, but the early steps in our efforts to combat the disease.
So you're saying we don't know yet?
Well, there is absolutely no way to know.
Okay.
This would be a highly speculative conversation. And that's one thing that I just want to make sure that everyone has to have an understanding that medical community in the United States, we at the Cleveland Clinic are very well connected, well integrated, and information is about best practices are flowing freely. We are adjusting and accommodating both our capacity as our practices based on the most recent knowledge and the information that we have. So it is a fluid situation. I would not like to be bogged down in the speculations. We're preparing in the best way that we know how, based on the information that we have.
Can you give us any more details about the drive-through testing, when it's going to start, where it will be, and who will be tested?
Yeah. So when it comes to the testing, what Cleveland Clinic has done, and we have Brian Rubin here to speak a little bit about our ability to test. We have developed our ability to test for COVID-19 internally in Cleveland Clinic, because we are going to be able to do it on site. Means that it's going to have a substantially shorter turnaround time, and we're going to have an ability to serve our patients more expeditiously. I'll invite Brian to speak about our projected capacity, and then we'll speak a little bit about our plans, about how to first screen patients. That's the first step before testing. I mean, we have to determine which patients actually need to be tested. That's the screening process is the first step, and testing is the second process. So please, Brian.
So we are live now with testing at the Cleveland Clinic. We have the ability to test our patients internally. Our current capacity, yes, so we can test about 500 cases per day right now, and we will be, by the end of next week, we should be at about 1,000 cases per day that we can test. That's 1,000 samples or 500 samples. Some patients may have multiple samples being tested, but we will try to maximize how many, how we can run our testing so that we're the most efficient possible. The turnaround time has been slated to be around 8 hours. Of course, it varies a little bit. That's really the time it takes to run the test. And so what we've done is just eliminate the pre-analytical step of having to transport it somewhere else. That's why we're able to turn it around. We're not doing anything. We didn't invent a new technology here. We simply told ourselves last week, we asked how fast can we get this test online using our pre-existing equipment and so forth. We're just running the standard CDC assay. So again, we didn't invent a new test. We're using an assay developed by the CDC, but we brought it online locally so that we could serve our patients faster. And we will be working around the clock until further notice, testing 24 hours a day, 7 days a week here.
Yeah, how does that advancement of being able to test within the clinic change things for patients?
Well, the turnaround time is so much shorter. So previously, our turnaround time was in the neighborhood of 3 to 4 days. And so now we can rapidly evaluate people. And within 8 hours, for instance, we can determine whether or not somebody is positive for the virus. I also want to emphasize that actually it's flu season. And we don't know the actual incidence of COVID-19 right now because we haven't tested enough. But we know there's lots of flu out there. So the first test that we do for every patient is flu and respiratory syncytial virus. Once we've ruled them out, then we will go with appropriate exposures. And Dr. Gordon can talk to this. He's an infectious disease expert. But we don't necessarily test every single person who walks through the door and says, I think I might have COVID-19. There's a process. There's a questionnaire that they need to answer about relevant contacts and so forth. They need to be negative for flu. Then we will test. And so there's a process that gets them there. And that's really to conserve resources. If we want to test the people that are most likely to have COVID-19 right now and really target it towards those patients.
So how are you integrated with the CDC and ODH with this? Like if a person tests positive here, does that become a confirmed case, or does the test still have to go to ODH?
Yes, that's right. So if a person tests positive here, that's a confirmed case. The ODH will know about it. We send them our information. We update all the patients that are being tested and the results so that they know about that. We follow CDC guidelines, and so that's the way we integrate with CDC. We're following their best guidelines with all respects to practicing, not just testing.
So CDC didn't have to approve this?
No.
No.
So maybe we can speak about this. So there is a large amount of effort and coordination nationwide among all healthcare providers as well as the regulators, directed to our joint efforts to make the testing more available and to scale up an ability to test for all Americans. The things that have been done that will allow us to get to the desired capacity to test faster involve close collaboration between the Center for Disease Control, CDC. They have issued, it's essentially in layman's terms, a recipe how to diagnose COVID-19 virus. We know the structure of the virus, we know the process about how to diagnose it. FDA, which is the regulatory agency, has accommodated their criteria for individual laboratories in large healthcare organizations that they know have a capability to follow the instructions and get to the desired quality of the results, and then relaxation of rules, but not relaxation, but actually the flexibility that FDA has demonstrated will allow every laboratory with the similar capacities of a Cleveland Clinic to develop the testing capacity in a short order so that more and more Americans will have the that ability. Once the test is positive from the laboratories that will be testing, our only obligation is to report those numbers to the CDC and FDA. So that is a big and a very welcome step and a change and a response of both FDA and CDC to the suggestions of large healthcare providers like ours that we have shared in Washington, D.C. yesterday. And the response was prompt and it was very welcome. But I would like to use this opportunity to invite Dr. Gordon to speak about the specific steps when it comes to diagnosis and testing, because speaking about a misinformation and lack of accurate information, I think this is an opportunity to communicate clearly who should be worried, how should they approach it, what are the steps that are currently available and being put in place so that everyone who deserves care gets the care that they seek timely. So, Stephen.
Well, thank you, Tom, and thank you for being here. And as described, this is a fluid situation, and this is truly a novel virus. And we'll start by saying none of us have immunity to it, and that's one of the issues. But I think when we talk about, I've been practicing ID for a long time, I won't be able to tell the difference for a patient who has influenza versus COVID-19. And so there is no telltale diagnostic, laboratory, or physical findings. Hence, if it comes into the community, and as you all know, it looks like that it's certainly in Ohio, whether there's how much community transmission, as Dr. Mihaljevic said, we don't know yet because there haven't been a lot of testing, but let's assume that there is. Then it becomes an issue for us. Testing becomes important in making that diagnosis. But what I want to emphasize is, although we've increased our testing capacity, we still haven't met the demand that is out there, at least from the public. And there is tiered testing criteria. And what we mean by that is that it's not just everyone that wants a test. There are CDC guidelines for tiered criteria. And at tier 1, for instance, in that population, all of the people have symptoms, that is, they either have to have fever or clinical signs of disease, are going to be, for instance, patients that may be in our hospital with an unexplained pneumonia where other routine tests have been negative. We now have to think about the possibility, could that be COVID-19? Similarly, if we get a patient now from a nursing home or an LTAC with an unexplained febrile illness, it has to be in our mantra in terms of in our differential diagnosis. The fact that now we have capacity to have a test on site means the throughput time for that will be lower for those tier 1 patients. We also don't forget about other patients who maybe are coming from an area such as Italy within the past 14 days and maybe get a febrile illness. As was stated earlier, that could still be influenza, but these also are in the tier for testing in terms of for COVID-19. And so it isn't for everybody, and there's a lot of people out there we hear that I was exposed to someone who may have been exposed. We hear a lot of that. That is not clinical testing criteria, or people who are asymptomatic, that is, have no signs or symptoms of any infection.
How many have there been, have you done COVID-19 tests here at Cleveland Clinic? Do you have a number on it?
So we haven't done any in-house testing, but we were sending out to one of the big reference laboratories over the last several days, and we've had, I believe, 29 tests. They're all negative so far.
And those would have been Cleveland Clinic patients at one point?
That's right. They were all Cleveland Clinic patients.
So you're live, but you haven't actually done the test here yet?
I believe we have a run running right now, the first run. Yep.
As we speak, yes.
In a possible case?
Yes, that's right. We have some patients who are testing.
And you said you can do up to 500 cases a day.
Yep.
And what is the turnaround time for you guys? Is it
Well,
the results?
it's the test takes about 8 hours to run, so we were quoted as saying 8 hours, but it could be anywhere from 8 to 12 hours, I would say.
Are the results of all the tests that have been done through an outside lab now, have those all been reported to the Ohio Department of Health?
We've been reporting them as they've come in, but we have had some this afternoon, and I'm not sure where they stand, but we do report them virtually immediately to all of the providers who sent the patients to. ODH would have actually found out, but since it's done at a reference lab, the reference lab has been contacting them directly.
Can other providers in Cleveland use your services? Can UH or Metro use your testing?
Yeah, we're currently exactly coordinating with our partners, in particular with the UH, the stand-up of the designated facility for screening and testing that we will use jointly. Because
Is that the drive-through testing?
yeah, that is what people are describing as a drive-through testing. We will keep you informed exactly when is that going to become available and what is going to be the location. We're still, obviously it requires a bits of preparation, but we are here to share our capacity for testing to the maximum benefit of the communities that we serve, regardless of where patients are coming from and under whose care they're currently at.
Can you just explain, if someone comes in with symptoms that could be COVID-19, what determines if that person will in fact be tested?
So let me just kind of run you through the common scenario. First, people who do not have any symptoms but have questionable exposure would not be tested at the moment. So if you feel fine and you may have been in a contact with someone, you would not be tested. People who have a fever, dry cough, typically as the most common symptoms, if they were to come right now, they would be first screened. When we determine that there is an appropriateness of testing, they will first be tested for common reasons to have fever and dry cough, and the most common reason is by far influenza and respiratory RSV and the other types of virus. Only if that test is negative, meaning if people do not have influenza but have clinical symptoms that are concerning, would they be tested for the coronavirus.
Can you even estimate on when that joint, I'm just calling it.
Within the next couple of days.
In the next couple days?
Yes.
Okay.
So, just to be clear, so the Cleveland Clinic didn't create this
Yeah.
test, they just developed it?
So just to be absolutely clear, Cleveland Clinic has not developed a new test for coronavirus. What Cleveland Clinic has done is used the publicly available information from the Center for Disease Control and have followed the guidelines internally to develop the testing capacity internally. The reason why we have been able to do it, and we have been able to do it quickly, is because our team has focused all of our organizational resources and an immense amount of work to get to the desired result as quickly as possible. So that is the only difference. The reason why our turnaround time is not measured in days, but in hours, is not because we have a different test. The reason for that is because we have a test on site, so we can eliminate the time-consuming parts of the testing today that includes obtaining a sample, bringing it to the central laboratory, waiting for the result, and then bringing the news back to the providers. That is the only difference. The test that we are using is the test that is widely described. It is the test that CDC has essentially shared all the necessary steps with everyone else. And we were doing it with the equipment, people, and reagents, meaning the chemicals that we had available internally.
But is the clinic the first hospital to begin doing on-site testing?
This one of the first. I was on a call right before I came here with the CMS and CDC and FDA. If I understood this correctly, there are currently about 10 to 14 laboratories in the United States, hospital laboratories in the United States, that are either about to develop that capacity or have developed that capacity.
And with the goal or the ability to get to 1,000 samples being tested per day next week, do you anticipate that will be enough that's needed? Because I mean, in a region this size with more than 1 million people, are there plans to increase that capacity?
Yeah.
Is that even possible? Can you speak kind of to?
Yes, it is possible. I can just address this briefly. It is possible to scale up that capacity even more with an additional equipment that we are waiting to arrive, that is going to automate a lot of process that is currently being done manually. But I think what is a really big hope on a national level to increase the availability of the testing is the expectation that most large laboratories in other institutions, medical institutions, which are very many in the United States, are going to develop a similar capacity in short order so that we can all together, for the benefit of our greater community, have the sufficient number of tests available.
What number do you think you
Wait,
can
real
get
quick,
to?
everybody, and I'm sorry to interrupt, we're gonna take 2 more questions, and then Dr. Mihaljevic has to leave.
Yeah.
But then our other experts are gonna stay here to keep answering questions, okay? So
I
go
was-
ahead, Dr.
I
Mihaljevic.
was just gonna ask, can you talk about how this is a game changer for the country, for our local community?
Well, it is a game changer for a local community that, you know, in the times of need, Americans in general, healthcare professionals in particular, always band together and show the best and the brightest side of our communities. And, you know, we're standing in front of you today, not only because we have developed something that is unique for the Cleveland Clinic, but because we're the part of a greater nationwide effort to serve our citizens in the best and the most responsible way. So if I were to speak about a game changer, these type of needs are really a phenomenon. It's a really inspiring vehicle that brings us all together in a ways that is much more effective. People collaborate, share information, we share resources, and we're in it together. I'll take one more question and I'll have to excuse myself and leave, but my colleagues know and the answer to, I'm sure, most of the questions that you'll ask. So please, one more question.
For models, you're talking about, you know, we got the South Korea model where they're testing people 1,000 a day, then you got Italy closing down the country. What other model would you like
Yeah.
for Cleveland to?
Well, the testing alone is important, but it is not going to give us the desired results. As I spoke at the very beginning, there are 3 steps to the process that will ensure success in us handling this pandemic. One is to make clinical care, accessible to every American, regardless of their socioeconomic status and ability to pay and whether they have or do not have an insurance. The second one is to, what we spoke a lot about, is to scale up the efforts to have tests available to all of those who are in actual need of being tested. And the third one, and this is a big societal effort, that once people are identified to have a disease, to make sure that they can stay at their homes and be quarantined and prevent the spread to others by ensuring that they have all the means that they need in order to stay at home without fearing for their jobs or their livelihood. 3 steps, very, very important. And I would say the last part is we can do a lot by helping our patients in a direct contact. This is a wonderful opportunity for us to use technology. One tool that we have historically never had at our disposal is a digital interfaces for healthcare delivery. Telemedicine is a service that Cleveland Clinic offers and encourages our patients to ask for the advice when it comes to their concerns or fears by using our Express Care, our apps, our digital media. That will keep them at home, that will allow them to get the most appropriate counsel, that will increase our ability to touch as many patients as possible, and that will substantially reduce the risk of others acquiring the disease. So I will urge everyone to use the technology. This is a wonderful tool. Telemedicine, digital interfaces. Each of us has a phone. We are just one click away from you. Okay, so I thank you very much for being here today. Thank you very much for what you're doing to inform the public, and I'll excuse myself. I have to leave. Okay, thank you. Thank you very much.
And please feel free to ask our other experts questions, just keep going.
Quick follow-up for you on the supplies. You had mentioned the mechanical ventilators and the beds. I'm curious about the N95 masks and how we're doing with that supply, because that was something that's also been, circulating all over the place.
So we have adequate supplies of all types of masks, including the N95 mask currently. When we first started listening and learning about potential infection in China, we started to look at expired supplies, and expiration dates are usually very conservative. We started holding on to masks that we could use if the pandemic really came about. So we do have adequate supplies. That being said, we're kind of judging, okay, how many do we use a day, under what circumstances? So for anybody who's testing a patient for a potential COVID infection, they will be wearing the N95 masks. For any patient in the hospital that's identified, whether they're in the ICU in a regular floor, those nursing personnel will also have an N95 mask. Anybody who's doing a test on a patient, like an upper endoscopy or bronchoscopy looking into the lungs where your exposure is much greater, or in surgery, they will also use N95 masks in combination with face shields. Others who are less intensely involved will use regular surgical masks, face shields, gown, and gloves. Steve, do you want to comment?
And do you have a number on it roughly? Like we mentioned 550 ventilators. Is there like roughly a number of how many masks you have?
We have adequate supplies.
No, so as Dr. Wyllie mentioned, our infection, part of this is detection, and that comes with testing and having a suspicion for infection, and that is going to be driven by the epidemiology. The other we talk about is protection, and our greatest asset is our healthcare providers. And so we need to keep them, that's a high priority, obviously, to keep them safe, to make them feel that they're comfortable taking care of not just COVID-19 patients, but other patients, flu, other things that we see, tuberculosis. So one of the other things has been practicing, drilling, donning, doffing, and trying to get a cogent message out about that protection from the time a patient might enter at our healthcare center all the way until the time any patient might be admitted, and to continue to monitor that. So we're very important about that. In the other, we said it was isolation, but you don't do isolation usually. You want to think up front about the possibility, not react necessarily to a positive
I
test.
have a question about the cost for the test. So will it be free for people to get the test?
So Tom announced earlier today that we're not going to charge any copay for testing. If there is coverage, if the patient has insurance, we will be charging the insurance company, but we will not be charging any copay for insured or uninsured patients.
You kind of touched on this throughout the press conference, but can you kind of touch on the overall conservation plan that's in place to, preserve the supplies and how, the thought process and when you use certain things and when you don't?
So this isn't new to the current infection. This started with Ebola 8 or 9 years ago. Went through the Republican National Convention in Cleveland, where we were worried and practiced on bioterrorism. We've also met with our counterparts, so University, Metro, St. Vincent's, the county, as well as the city health departments, as well as the state health department, in terms of coordinating all our activities. So it's really coordination among all the systems, because if this reaches pandemic levels, then it's not going to be the Cleveland Clinic in isolation. We'll have to coordinate all the resources in the state of Ohio, and particularly the hospitals in Northeast Ohio, will band together. So the chief medical officers are meeting to look at how we might test together, and where we can test, and how we can share those resources in terms of those capabilities.
I have a question about testing, actually. So the testing that's going on with the Cleveland Clinic and the testing that's going to be happening soon with university hospitals, will that be in the same testing center?
We were talking about that earlier in the day, so we're exploring that opportunity, actually.
I would say we really don't. We have the sense that we need to keep ramping up, and we want to be as capable as possible. And so our goal currently is just to get more devices and start expanding it. But we don't, Dr. Mihaljevic sort of stated it well, that this is really new territory for all of us, and we don't know exactly what's going to happen. We hope that we're intervening early enough in this epidemic that we can squelch it and not need as many tests and supplies and so forth. But the reality is we don't know, and we're just, I think you can safely say that we're pulling out all the stops that we can right now to be ready in case we need it.
So are you manufacturing your whole supply, or is some coming from the CDC or?
No. So we depend greatly on vendors who provide, for instance, PCR machines would be a basic, one of the machines that we need to do this test. since it's a nucleic acid-based test, and so there's reagents as well, and so we manufacture nothing here. We're completely dependent on outside vendors, but we have a close relationship with them. The vendors are being as user-friendly as they possibly can, but they have to distribute supplies nationwide. The goal is to really get testing out just beyond the Cleveland Clinic to every capable pathology and laboratory medicine department in this country. And so nobody can be hoarding supplies and so forth. And they're trying to distribute things very equitably, knowing that there's going to be this demand nationwide.
But these 500 that you have, I mean, I guess manufactured might not be the right word. You've got the formula and you cook that up, right?
We have everything in-house. We need to do those for quite a while. Yep. Yeah, we can remain at our current capacity for a while.
How
I want to
concerned are
switch
you?
gears 1 second and talk about, I know you changed your visitation policy. Can somebody speak to that in terms of like people coming to the hospital, what's the changes?
This is hot off the press. We just announced.
So the changes, and we're announcing in concert with the State Medical Board of Ohio. So once we had a community spread of COVID-19, we're going to start screening people at all our hospitals and all our other healthcare facilities, which are ambulatory. We'll screen them just at the door or just before they get to the door. If they are ill with an acute respiratory infection, we'll ask them to get evaluated, but we don't want them visiting people in the hospital who are already ill. We're going to limit the number of entrances to our hospitals to a couple so that we can manage the ingress and egress. We're going to do the same thing with the vendors in terms of keeping vendors out who aren't clinically necessary so that we limit the exposure to the patients. We're going to limit visiting hours from about 8 a.m. to 10 p.m. So if you come visit after that, we will let people in if they're coming through the emergency department or if they're being transferred from another institution, but we won't let people just walk in through the regular channels in the regular door. And finally, we're going to ask people to maintain cough etiquette. So if you're going to cough into a tissue or sneeze into a tissue, get rid of the tissue, wash your hands for 20 seconds, use an alcohol sanitizer with at least 60% alcohol. We're also limiting visitations in terms of children, so we're asking people if they're under 16 not to visit. We will make Skype and FaceTime capabilities available, so we don't want to isolate patients. But in general, we want to reduce the number of people coming into the hospital. We're going to limit the visitors per patient to 2 a day. And the reason we got to 2 is because we know in an aging community like Ohio, there are a lot of elderly couples who need support by a third person. That could be one of their offspring who's now an adult and bringing them in. So one of them may be seeking care, the other one may be coming along, and somebody to support them both. So that's why we went to 2 people. We'll be compassionate, and patients in the end of life, we'll make appropriate accommodations for those situations and make sure that we do the best we can. But it's a way to protect the people in the hospital once the COVID-19 is in the community, and the governor announced a couple days ago that with the 4th case, that it was community acquired.
I'm sorry, I want to make sure I'm clear on this. You said you're going to screen everyone coming in the door?
Yes, we will ask everybody who's coming in the door a question about, do you have an acute respiratory illness? Have you traveled to an area which is endemic or has sustained community transmission? We'll ask if you have a fever. And if you have those things, we're gonna ask that you get evaluated, but we don't want you coming in to visit somebody in the hospital.
Will that apply to employees too, or just visitors? Who does that apply to?
We've already instructed all the employees. We're telling the employees, if you're sick, don't come to work. We're also asking people just in general to use our telehealth capabilities that Tom talked about. Don't come to an ED if you're sick and have a fever and you really don't need an IV and you're just feeling bad, but you're not feeling bad enough to be hospitalized, but you have a question about what you might have. Instead of walking into a doctor's office and waiting room or walking into an ED and waiting and contaminating other patients, call. From there, we can do a virtual visit and we can instruct you from there about what the best course is going to be.
What about for outpatient surgeries? Do you recommend people dropping people off, leaving the hospital, let the procedure go through, and then come back?
So for outpatient surgery, we're going to limit the number of people waiting on a patient who's undergoing surgery to 2, just like we are in the hospital with the same restrictions. But if they're ill, and we're going to remind people with messaging, if you're ill, don't come to the hospital if you're ill for surgery, for elective surgery. You know, particularly if you have a respiratory symptoms like cough and fever, because that would not be advisable for anybody else that's around you, nor for the people trying to care for you.
We'll take, does anybody else have a question or want to do a one-on-one?
Yeah, I have a
Okay, we'll do
question.
one more.
Okay. How is the hospital getting involved in collecting information on who's been exposed? Like if there's one person at an event who has coronavirus, how is the hospital gathering information on who they've been in contact with?
So that's actually the job of the State Board of Health and the County Boards of Health. They identify all contacts and follow up on those contacts and do the tracers. And they're actively involved, particularly with 3 patients which have been identified in Cuyahoga County, in doing all the tracers and following those patients. Steve, do you want to comment?
Yeah, I think that's, that's probably so, people are saying, well, I was at an event and there might have been someone that was diagnosed with COVID-19, what do I do? I think it's important principles is that, again, what we know about the transmission dynamics are evolving, but people with COVID-19 are most likely to spread to another person when they're sick, not when they're asymptomatic. And when we looked at you looked at the United States data, so if you looked at the 10 patients, the first 10 travelers who developed COVID in the States, and when CDC went back and looked at all their contacts, work, play, the only people that developed secondary cases from them were household contacts, and that was only 20%. So I think we want to keep things into perspective in terms of risk. So when we hear about, I was at an event and someone I said, developed COVID-19 in terms of this nature, that is not an exposure per se. And that's why we rely on the health departments to let us know doing the close contacts after investigation. That's different than someone saying, I just came off the plane, for instance, from Northern Italy, I'm in that 14-day period and develop a fever. Those are patients in, as we said, our tier 1 and would be queued up for testing, appropriate testing.
And again, you said in a couple days you might be doing the drive-through process, and
Yes, we anticipate standing that up in the next few days.
what would that, how would that work though? Do you have that?
You have to have it.
Commute
You have to have a doctor's order. So somebody has to order the test and for appropriate indications, and we've outlined that in the electronic medical record. We'll make sure that we identify those patients. They'll actually be identified twice, and then we will do testing. So right now the plan is to have them drive into a tent area. They can even stay in their car. We can do the testing. They can drive off. We'll give them advice about the length of time it's going to take to get the test back and what they're supposed to do before they get the results back, and after the results for that matter.
One quick question on the testing. You had mentioned you could do up to 500 people per day at this point. Are you hoping to get that number up?
Well, we should be about double that number next week. And then I don't want to provide other numbers at this point because we don't have equipment beyond that number right now, but we are actively trying to obtain more equipment which would allow us to expand our testing. So we do hope to do that, but we just don't have the testing in-house right now, or the equipment in-house.
So 500 per day for now.
Yep.